Hello, good afternoon. Whoever, this is a Hoya sponsored session on astigmatism management with the toric IOLs. I'm chairperson, Dr. J.K. Reddy. I got a co-chairperson, Meena Kumari, and a moderator, Mari Chigma. Dr. Atishwar. Now the first talk is on advancement preloaded IOL delivery system, multi-set injector by Dr. Ganesh V. Raman.
Thank you, sir. At the outset, I'd like to thank the Chairman Scientific Committee for providing me this opportunity. I'll be speaking to you on advancement in preloaded IOL delivery systems. And at the outset, I'll also like to say that I have no financial disclosure related to this talk or any financial relationship with this talk. So I'll be speaking to you. So preloaded IOL injector systems have many desirable features. They're easier to prepare, and they also increase the safety by reducing the risk of contamination and infection, and reduce the risk of IOL damage because the personnel doesn't handle them. And at the same time, you have depend less on the skill of the person loading the intraocular lens, and no chance that the forceps which are handling the lens will damage the optic of the lens. And it's more efficient in the OR, so you minimize time. Some studies have shown you save up to 33 minutes from manual to preloaded systems. And very few instruments are required to manage the situation. And it's also more predictable. Every time you don't have any surprises. It's predictable every time and very consistent. And this is the proprietary device from Hoya. And this is the multi-cert device. So you have the advantage of either using a push mechanism or a screw type 200 screw injection mechanism. So that's the advantage of a single preloaded delivery system, and it incorporates two ways of injecting the lens, which we are familiar with. And the other advantage of this device is you can have it linear delivery, also have it deliver into the capsular bag, especially if you're operating on a patient with a short axial length and you have a angle closure component, you have a smaller rexus, you want to be on top of the rexus, you could always have the nozzle out a little bit more and then be on top of the rexus and then introduce the intraocular lens right into the bag. So that's how the system works, and it comes in a ready to use pack. So you have a infusion port and you inject viscoelastic over that and remove the cover. The cover allows you to slide the slider forward and making sure that the injector pushes the lens to make the intraocular lens in position so that as you bring forward the plunger, the intraocular lens moves forward. So this is a small video to show how it works. As you peel it off, you have a hook at the back. You have a handling tab with which you can take it out, and you inject viscoelastic into the small opening there. And you have the cover. What you're seeing is actually the cover which you have to remove. Once you remove the cover, it allows the slider to bring the lens into the correct position for implantation. So this, once you slide it in, the lens gets a little bit compressed, the haptics gets compressed, and then you push the slider or rotate the slider. So it's a very convenient way. More than convenience, it's consistent. So you don't have lens breakages, you don't have eventful intraocular lens implantations. And what you have to pay attention is both the haptics have to be folded. And delivery into the capsular sheet, you can bring it back bring it forward as for a linear delivery, or you can take it back for in the capsular bag delivery. That's very advantageous, especially when you operate difficult situations. And you have single hand as well as two-handed implantation technique. So this is how it looks in live, and once you inject, you see the viscoelastic going forward and backward. And once you have filled this space, you remove the cover. Once the cover is removed, you push the lens into position by pushing the slider. And this is the, for linear delivery as well as in the bag delivery, you have the movement of the tip, and that's adjustable. And if you were to thread it, the intraocular lens moves forward, and if you were to push it, the intraocular lens will again move forward. So you can use either of these techniques for implantation. So in this way, it's quite consistent and very convenient. And that's the end of the surgery. So these they are available in the chromophore lenses as well as non-chromophore, and the resistance when you inject is very smooth compared to other push methods, and very high user satisfaction amongst the users of this device. You can always have it in the 9X version also. So the advantage of this is gives a lot of wound protection, outstanding delivery, and consistency and smoothness, and the 4-in-1 system provides a choice of push or screw injection, and you have the insert shield in advance or default position according to the surgeon's preference, and individual cases as you manage. Thank you for your patient listening.
Finished well in time, but it's a very nice system by Hoya. One of the, I think it's the best system in the world. What you say among all preloaded we use so far? So we use so many preloaded. Every company is trying to come with preloaded. It's MNCs or Indian, everybody. But so far I used, this is the most predictable and most consistent system. Very, very unusual to get a surprise. And at least, what is your opinion?
The injectors, almost 250 injectors are patented, more than that. So very difficult to copy and make your own.
No,
so this one is really fantastic in the sense it goes in very smoothly. You don't break any lenses. That's the main advantage of this.
Patents, it's okay. Patents are there to break only. So it's a patent is just for a.
No, what I'm saying is you cannot manufacture again and again.
You can, but we opened it up. We saw at least 20, 30 good systems, and to copy them, it's taking years to copy them. And coating and the material they use and the way it glides are strengthening. We are not able to replicate. We are still struggling. This is a fantastic system. How even initially they had few troubles, but now it's ultimate. It looks like the best system. They are it depends upon the lens also. The lens also designed for that particular cartridge. It is not every lens won't go into that. You put it, it will get stuck. And very much I like this is if you have a PCR, small PCR, something like that, whereas other lenses, other delivery, we don't know what is going to happen. We will be just praying, and we can inject it, then rotate it every micron, and we can nicely paste into the black when you are in trouble. This fellow will definitely help us compared with other intraocular lenses. And another thing is preloaded. Generally, when you're doing surgery, the staff will preload. Okay, he's doing cortex, let us preload it. But then it will retain its shape for a long time for recovery. So we have to train the staff. This which stage of surgery, better you give a call. Okay, load. Otherwise, the moment you take IA, they load it and keep it. It takes a long time to unfold the convex.
And we use only HPMC in these cartridges. You can't use Helon.
You can use, but you don't use Helon 5 or Viscoat or RO coat, something very thick one. You can use plain Helon. Not even GV also not very good. If you don't have anything else, you don't want to waste, put some water in BSS first and put a little bit this one, or you can just do it BSS.
I'd like to call up the next speaker, Dr. Tamilarasi, who would be talking to us about preoperative planning of toric IOL. She is a senior consultant at Eye Foundation, Coimbatore.
Good afternoon, one and all. Incorporating toric IOL in one surgical practice is really straightforward and easy option. The first step towards is doing an accurate preoperative planning, which I'll be discussing in the subsequent slides. Having a residual astigmatism of 0.5 to 0.75 in the postoperative period significantly decreases the quality of vision. And we know 35 to 40% of the patient undergoing cataract surgery have significant astigmatism, and toric IOL is a safe and effective way of addressing it. Who are all the ideal patients? Patients who are having a regular corneal astigmatism and having a healthy ocular surface. My absolute contraindication would be any capsular bag compromise, a large PCR or zonular weakness, which will preclude from aligning the lens intraoperatively and maintain it in the postoperative period. Beginners are advised to start with moderate degree of astigmatism around 1.5 to 2 diopters, because we know that for every 10 degree of rotation, that is 33% of loss in the astigmatism correction effect. So if you're going to correct a high astigmatism, for example, 4.5 diopters, for 10 degree rotation, we'll end up in a residual astigmatism of around 1.5, which will be disheartening for a beginner to start with. I'm going to describe how the cataract patient's workflow happens at the Eye Foundation. Once a patient is diagnosed to have cataract, the first and foremost thing, even before any contact or dilating drops, we do is subject the patient to optical biometer in centers where we have, and we run through the Barrett TK toric formula. The TK stands for total keratometry, and the toric formula, which gives the toricity of the lens to be implanted. In centers where we don't have this, we do the manual keratometry, and this magnitude of astigmatism acts as a base from which we start our counseling. If the patient wants spectacle independence, then our counseling will be straight ahead multifocal toric, rather than counseling the patient for multifocal, and rather after we do a biometry and we find a significant astigmatism, recounseling the patient for a multifocal toric is going to be a painful task. The second pearl is what is a threshold, for which we have to understand what is the posterior corneal astigmatism. The posterior cornea is steeper vertically, and hence it creates an against the rule astigmatism. So it adds to the anterior against the rule and it lessens the anterior with the rule. This is better explained with this toric power calculation sheet. To the left we have 0.75 against the rule astigmatism, and after taking into account of the posterior cornea with the calculator, the corneal astigmatism here, it is around 1 diopters, for which we need a T3 toric model. Whereas for 0.75 with the rule astigmatism, after taking into account of the PCA by the calculator itself, the astigmatism becomes around 0.19, and it suggests a non-toric IOL. So we should understand that there is no cutoff, and we should understand it is different for with the rule and against the rule. And also, if you're planning a premium IOL, multifocal IOL, even here, even for a 0.74, we need a toric IOL, because any residual sphere or cylinder in a multifocal IOL, the visual quality is going to decrease, and this is going to cause patient dissatisfaction. So around 0.75 of against the rule and 1 to 1.25 of with the rule, put your measurements in the toric calculator. We can use even online Barrett toric calculator and see if the patient is requiring toric if opting for a multifocal IOL. Always it is better to start with accurate measurements so that the spherical power calculation is going to be accurate. Do one need to own the most advanced technology like optical biometers? If one has, it is well and good, but it does not prevent them from offering a premium IOL. What they have to concentrate is to have a well-calibrated equipment, and we should understand that optical biometry is idiot-proof. That is, inter-observer variability is going to be less. Whereas if one is going to operate a manual keratometry or an immersion A scan, we should have a well-trained staff so that the readings are correct. Once we acquire the axial length and K reading, the spherical power calculation, our go-to formula is the Barrett Universal 2, which works across all axial length. Coming to the keratometry per se, we have multiple technology. One thing we should understand, everything has its own technique and different measurement areas. What one has to do is compare the data from more than one modality, and a close agreement can be sought for. If you don't have another modality, repeat your measurement from the same machine on a different day if possible, or not in the same day after some time. And it should be repeatable. If not, look for ocular surface irregularities or causes of irregular astigmatism and treat it. Axial length is best obtained by optical biometer, and if not, a well done immersion A scan having a good quality spikes which are steeply rising and are of equal height is going to give us the good axial length. Once a measurement is obtained, the technician and also the surgeon should know whether the quality of the data is correct or not. If you're going to put an inaccurate data even in an advanced calculator or advanced formula, we are going to get an suboptimal results. So how we can identify whether the data is correct or not. Even if the other eye has been operated, put in a pseudophakic mode and compare both eyes. Any difference in the axial length, keratometry or the IOL power between the eyes, remeasure and confirm whether it is correct or not. And also correlate clinically. And uniocular criteria, as I said in immersion A scan, we can see for the steeply rising spikes and are of equal height. In optical biometer, we have the signal to noise ratio associated with green signal, which tells that the value is correct. And also in IOL master, we have this foveal fixation check. And for keratometry, look for the standard deviation value, which has to be low. And these LED points, which we are seeing, should be crisp and clear. If there is any teardrop-like appearance, the ocular surface disease must be taken into account. Look for it, treat it. This is one case scenario. We can see that the dry eye disease, the magnitude and also the meridian between the two eyes is different, 0.5 and 2.67. The slit lamp examination revealed the dry eyes and the patient has been put on lubricants, and after optimizing the ocular surface, we could get almost similar values both in magnitude and the axis of astigmatism. Topography and tomography role we don't routinely do in normal cases, but in case if you're suspecting the ocular surface disease or to look for causes of irregular astigmatism, and in post-surgical corneas it is indicated. Like as I said, about 30% of the patients need additional measurements and treatment. By taking care of these patients, we can achieve good equivalent results in all our cases. And also we should know what toric calculator we are using and how these factors are taken into account. What is there to account for posterior corneal astigmatism, how they are taking into account of the toricity ratio, and what is the value we are entering for centroid SIA. And this is the Hoya online toric calculator which is available, and they have this Abulafia-Koch regression. It should be kept on if you are using the standard anterior keratometry values. But if you are using the TK value, it should be kept off, and this takes into account of the posterior corneal astigmatism. And when you are entering the value of surgically induced astigmatism, the centroid value should be taken, and for any clear corneal incision less than 2.4, the value is 0.01 diopters. And the incision location, I usually go for 180 in right eye and 0 in the left eye. And this axial length value which you are entering, the IOL power and the keratometry, all three along with the Holiday formula calculates the effective lens position and gives the toricity. This is how the toricity ratio is taken into account. For a myopic eye, the IOL is going to sit posteriorly and is going to require a different toricity, higher toricity. Whereas for a hypermetropic eye, the lens is going to land little anteriorly and the toricity ratio is going to be less. So this is how this is also taken into care by this online toric calculators. And when choosing the type of lens, always go for the lens which gives the least residual astigmatism. This is option 3. Don't worry about flipping the axis, that is leaving the patient with little with the rule when you're treating the against the rule. This is acceptable with intraocular lenses. So by doing a good pre-op calculation and nailing the IOL on axis, we can achieve good results with all toric IOLs. Thank you.
Dr. Tamilarasi, your talk was very good, and would you recommend that every patient whom you counsel for cataract, you take them through the IOL power calculation strategies?
Yes, ma'am.
Do you put them for calculators and then take a decision if they need a toric IOL or not?
First, we do the optical biometry and then only start our counseling. If the patient have astigmatism, then we explain that they have astigmatism and toric IOL is available to correct it so that they get good distant visual acuity. And if they are opting for a spectacle independence, we do counsel them directly for a multifocal toric.
Thank you.
Thank you.
Good afternoon. This is a lunchtime symposium. Don't expect much.
So Dr. J.K. Reddy would be talking about rotational stability with the toric IOL factors and taking into consideration Vivinex toric platform.
Yeah. What is the point to be considered in general, not about the Hoya lens, in general, early post-op rotation and the late post-op rotation in the rotational stability of the lens. So the ISO standards, they recommend for 1 year study of the lens. If you put a lens, any design of the lens, the manufacturer, they have to put in the eye and record, and after 1 year, they have to give what is the rotation. If it is a plus or minus 7 degrees rotation, then that lens will be allowed for correcting the toric IOL They cannot just launch any lens. They have to do the study. That is the ISO standards. So this is both immediate. It covers up to 1 year, not 3 or 4 years, up to 1 year. 1 year you have to give that result, plus or minus 7 degrees rotation. So the early post-operative consideration for the surgeon point of view, the speed of unfolding, this is very important. If the IOL rotates very, very slowly, so even when you put it in the axis, it is unfolding a little bit slowly, you would land up with another different axis by the time patient walks out of the operating room. This depends on the haptic design and strength of the optics. It is not the thickness of the haptic, the strength of the haptics depends how fast it will reopen, and loading also. So in doing the toric IOLs or multifocal toric IOLs, you load just before you inject. Don't wait for a long time. If you wait for a long time, they take more time for unfold. Then what are the late post-operative concerns? The capsular bag contraction is the big issue, like in pseudo-exfoliation or irregular anterior capsule rhexis. A rotation of IOL due to the compression of the capsular bag, which often happens in pseudo-exfoliation cases. And IOL material and haptic material and haptic thickness and strength also makes a big issue in late post-operative rotation of the toric IOL. So coming to the Vivnex, they launched some time back a toric IOL on a Vivnex platform. It was not doing well. They have withdrawn the product. So they find out where are the problems and solve the problems. They launched a new one. And if you remember, the first lens also got FDA approval for toric implantation. But still, clinically, it has not given the good results. They got FDA approvals but on the studies, but it's not given good results. So then you can decide now what is meant by FDA approval, how they do it. Then the new one, they have changed a little bit. They say only the frosting of the haptics. I don't think that's alone. They changed a lot of small things. Even in beginning, I was very skeptical. They're saying that just put two frosting dots, and the haptic is not going to work. They then challenged, use doctor, 4 lenses we are giving. Anything happens, I pay full amount for the patient refund, full surgery refund. They're fantastic, the stability. I don't need to wait on the table for 2 minutes before shifting my patient now with the Vivnex lens. I will sit within 10 minutes, within 10 seconds, 20 seconds. The other lenses, we wait for a minute at least to stabilize it. And the size of the lens also is not very big. It's not 13 millimeter or 13.5. It is only 12.5. And they are able to 12.75. They are able to manage some different in the material and the frosting they did. So the rotation stability is excellent. And opening is also very fast. The haptics, they are frosted like this. So they grip this capsular bag. That is their concept in designing a toric IOL. Not only the haptics. Then they have airspaceity. They did little bit tweaking so that even the lens is a little bit decentered from the pupil. Maybe 0.4, 0.5 millimeter. You don't lose too much loss of contrast like in a typical aspheric lens. The rotational stability, they have done the studies like I told you. Every lens has to go for under FDA study and show the rotational stability to be fall within that range. And this is doing much better than recommended range. Less than 5, they are become 7 degrees. Most of the cases they are within 5 degrees of rotation post-operative. That is 1 year. This is not 5 years, 10 years. So this is the lens. This is a plano convex lens, and only the haptics are frosted, and it's got a blue blocker to reduce the glare. And you have 3 lines. So even in the small people, you can visualize them very nicely. And the ranges are there with a coming to a constant of 118.9. This is they don't mention in the cartoon it is optical or ultrasound. You have to talk with them. Mostly 118.9 is working with optical, but some optical biometer they need 109.1. I found to get a good value. If you are using a high cylinder value like 4, 6 like that, try to err the spherical error by 0.5 diopters less. If you use exact value post-operatively, you're landing up with a slight myopia. So if you want 100% zero refraction post-operatively, you in a high cylindrical value like 6 diopters, 5.7 diopters, 5.25, 4.5, you err little bit under correction. If you get a 21 diopter lens, order for 20.5. If you get 23, order for 22.5. That works very well. Thank you very much. If you have any doubts, we can discuss.
Sir, I think the newer version of Hoya, Vivinex Toric was due to increase in size of the optics, which was contributing.
You go there. Type. See, then another thing is, so many years in A-scan, we are concentrating only in the axial length. Axial length is going wrong, axial length is going wrong. But now all of a sudden, when you have optical biometer, it's gone. Axial length is correct, now K reading. Same machine, you take 10 time K reading, you get 10 axes and 10, because basically it is a face tilt and it's a dynamic K reading because of the lid movement. So you put a tropic mat plus, the lid goes out, 1 K reading. If you put a 1 drop of phenylephrine, different K reading you get it. So which axis you use at which K reading? Added to that confusion, again you put in Graham Barrett, he changes his K reading from the preoperative K reading and the IOL axis, he says you put, if you get a steep flat meridian 90 degrees, he says you don't put in 90, you put in 95 or 105. So these are so many variables. These are all experiments on us. It's nothing less proven. They are all calculated. Only it's all they are experimenting on us. Once we give feedback, again they recorrect it.
Thank you, sir. Thank you all for this opportunity. And I'm talking about Hoya product, Vivinex Geometric Trifocals, cream of the cream. Because there are so many trifocals existing and trifocal torics too. There's no financial interest to disclose. And the limitations of older multifocals, we have come a long way ahead of this. The partial spectacle independence or decreased contrast sensitivity is still existing in all IOLs. And pupil dependency and increased glares and halos, the photic phenomenon. And need of the hour, give the best, optimize your outcome. So what's the critical success factor for trifocal implantation is accurate biometry with all the validation guidelines. There's much more in validation guideline, as Dr. Tamilarsi said, and precise A constant and IOL formulas, and go to the extent of customizing your own A constants and dry eye workup, certainly yes, aberrometry workup and angle alpha workup and counseling of the patients. Angle alpha, angle kappa. So angle alpha workup, why is it important? The IOL tends to center on the limbal center, not over the visual axis. If trifocal IOL decenters, patient sees through diffractive rings and not through the optical center, the central bull, and it will induce higher order aberrations. A large angle alpha, that is more than 0.5 millimeters, combined with the multifocal or toric, gives compromised vision. The result is potential complaints such as blur, double vision halos, and the patient will continue to chase you. Every day will be nightmarish. And you have to look carefully into each and every data, either the optical biometer gives or swept source gives. And the aberrometry workup is also important. At 4 mm of pupil, 0.3 microns of higher order aberrations will produce a blur similar to 0.5 diopter defocus. So trifocal technology, whatever could be the IOL, we don't implant if higher order aberration is more than 0.7. Coma is greater than 0.3, trefoil is more than 0.4, and tetrafoil more than 0.3. And Vivinex geometric family, trifocal family, this is a diffractive optical design. This is a newer lens in the market by Hoya. And our patient came 1 month post-op just yesterday, very happy patient, and we have used on 3 patients. And this geometric diffractive phase profile, it's patented, and it has got a truncated area. It comprises of 4 diffractive zones within 3.2 mm, or it has got 8 rings paired, and negative asphericity to correct positive corneal spherical aberration. And their intermediate add is plus 1.75 diopter, and near add is plus 3.5. And the long-term outcome of any trifocal depends not only on the optics, it depends on the material, design, geometrical design and also preloaded injector system. This is on Vivinex platform, and the toricity of the Vivinex toric IOL is proven now, and we are no more the rotational stability of Hoya lenses are of any concern. And this is a glistening-free hydrophobic acrylic IOL material, and it's got proprietary aspheric optic design, and this improves image quality. And they have a patented technology, oxygen processing treatment, and a smooth surface and a square optic edge. This is supposed to reduce the PCOs, and textured optic haptic junction, J.K. sir was telling, and the fibronectin and adhesions and all that, so that rotational stability is good and reliable outcome. So along with this, this again talks about the diffractive optics and the refractive center and preloaded system. Here, if you see, they've got two IOLs, either in the trifocal segment or in the trifocal toric segment. There are two components of light distribution. The light distribution is optimized so that the geometry optics, it gives good amount of light distribution for near and distance, and excellent for distance, infinity. And the geometric plus, the light distribution is such that the diffractive components have been the height of the diffractive rings. All the technology has been designed in such a way that this geometric plus is excellent for near, and it is good for intermediate and distance. So these paired options, one in geometry in one eye and geometry plus in the other, is very complementary to the patients. And this is their distance light distribution in geometry plus, and also in geometry, how it is distributed. And this is about the modular transfer function. This is an in vitro test done by the companies to judge the quality of light distribution depending on the pupil. And this is my experience with Vivinex geometric trifocals. And geometric trifocal, this is a defocus curve. In our institute, Dr. Shruti Vaishali, she is an IOL consultant, biometric consultant with us, and she does a defocus graph plotting, and it's very satisfactory. And also we did this is about the geometric toric in both eyes. Patient in 1 week post-op, they had small negative dysphotopsia, and yesterday we saw the patient did not have any negative dysphotopsia. That ensured that the adaptation component is quite good. And conclusion is, along with this technology, you optimize the outcome by adding the your biometric component as well. That's what I'd like to say. Thank you.
Yeah, thanks, Dr. Meena. You explained very nicely what are all the points to be taken. But this multifocal, they give more trouble than whatever they tell there will be something will be added. Now I call on Dr. Shreyas Ramurthy on toric IOLs in irregular cornea. Monofocal is okay, one trouble. Bifocal is double trouble, and trifocal is triple trouble. So one trouble I think is okay. Anyway, we have one more trouble always, man. The two troubles. Now 3, 4, I think it's after certain age. Up to 40, 45 it's fine. But after that 3, 4 troubles is not good.
Thank you, sir. So I'm going to be talking a little bit about toric IOLs in irregular corneas. Where can we use it? Some do's and don'ts. And again, let me assure you that Hoya has nothing to do with irregularity, and it is just a random talk. So a little bit of this was already touched upon by Tamil Madam earlier during her talk, and where essentially before we go into irregular corneas or irregular curvatures itself, there can be irregularity in measurements, primarily because of ocular surface disease, and this could be something as simple as a run-of-the-mill dry eye, and that's why it becomes very, very important to ensure that the first thing that you do, the first investigation that you do for a patient when diagnosed with cataract is to do a biometry even before any dilating drop or applanation tension or paracaine, any drop is instilled. Because a patient with a delicate balance in their surface can start developing punctate epithelial erosions with these drops, and this can significantly affect the quality of the measurements and repeatability of the instruments. And this is just one such example as already shown, 2.5 diopters of astigmatism on the initial biometry, but on examination patient had a lot of punctate erosions, lubricant started, and then you can see after a few weeks that there is absolutely no astigmatism on the repeat biometry. This is not something which is rare and happens quite often, and it's important that we treat these surface issues aggressively, use topical steroids wherever necessary along with lubricants, cyclosporin, and then subsequently repeat the measurements. In case you are not able to get consistent measurements varying in magnitude or direction, better to avoid a toric IOL altogether. Now going on to the little more difficult set of patients wherein toric IOLs are really for orthogonal astigmatism. And if we are using them in irregular, then it does come with a disclaimer that we are not looking at the same level of accuracy, or the aim of emetropia is not there. It's really about debulking the amount of cylinder. In keratoconus, whether it's a center or decentered cone makes a difference. Whether the patient was a previous RGP or Rosque user, the patient was already a contact lens user, is willing to wear contact lenses in the post-operative period, it's best that we just implant a spherical IOL. The reason is, if you implant a toric IOL and then put the patient on contact lenses, you will end up uncovering the astigmatism which has been corrected by the toric IOL, and the patient will require glasses for the power that you have corrected in the toric IOL, and this makes it an even more complicated and unfortunate situation. Repeatability of K readings, not just in terms of magnitude, but also in terms of direction. The vector is very, very important, and that needs to be looked into in not just one device, but 2 or 3 devices to look at repeatability of K readings. You could also optimize the extent of keratoconus before cataract surgery, and I'll talk about it briefly. The other challenge that you have is that most of the formulae assume a fixed ratio between the anterior and posterior curvature. And in keratoconus, we know that this curvature can be altered. The posterior corneal curvature can be even more steep, and when this ratio changes, the standard formulae may not be as accurate. Regularizing the surface before cataract surgery can also be useful. This is just one such example where you don't get repeatable K readings. After a topographic guided PRK, this patient has a much more orthogonal astigmatism now, much more repeatable K readings in magnitude and direction, and you can implant a toric IOL safely in these patients. This is a little more advanced cone wherein the K readings are all over the place, and mind you, this affects both spherical as well as cylinder. Even if you are not planning to implant a toric IOL, even for your spherical power calculation, having repeatable K readings is very important. And you can see after intracorneal ring segments, the cone is flattened significantly, and now you get a much more repeatable K reading. The cataract surgery itself is very, very simple. I'm just highlighting this particular video. In case a laser is being used, the edges of the rings can cause a little bit of diffractive effect, and the laser may not be focused very accurately, and it's important that we gather the rexus to the center before we go ahead with the surgery itself. Contact lenses, if necessary, like I said, avoid toric IOLs specifically. Go in for a spherical and make them use a contact lens postoperatively. Aim for a slightly myopic outcome. And of course, you have options of a piggyback or even a bioptics if necessary in these patients with residual. With PMD, it's less of a problem because the irregularity is less in the central cornea. So generally you get more repeatable readings, only that the astigmatism tends to be a little bit on the higher side, and you may require a customized toric lens rather than the standard IOLs which you have. In a post-transplant situation, generally it's advisable that you either complete all the entire suture removal, or if there are some sutures left for a long period of time, the astigmatism has been stable, has been at an acceptable level of astigmatism, then a few of those can be left as it is, and even if they disintegrate over a period of time, long period of time, they may not have a significant effect on the graft-house junction healing and will not affect the final astigmatism. repeatable topography and K readings are important. Again, as I mentioned, debulking is the aim. In this particular case, you can see there are 3 sutures already in the cornea, but the astigmatism has been stable for a long period of time, and the patient has, over a duration, has developed a steroid-induced cataract. And then subsequently, these are generally soft cataracts. In a post-PK situation, you just have to be careful that you use adequate endothelial protective agents before you go ahead. You may require a toric IOL, a customized toric IOL. This is a patient in a post-DALG situation. Again, cataract in a similar steps are done, but this is a Ultima Smart Toric lens being implanted, no financial interest, but they can debulk even high degrees of astigmatism, and these patients do very, very well. Again, we are not aiming at an emmetropic 6.6, but even 8 to 9 diopters of astigmatism can be corrected very, very well with these customized toric lenses. Just a word about Fuchs before closing. In case it's a early Fuchs and you're planning a cataract surgery directly, just be cautious that a little bit of epithelial widowing that the patient may have in very, very early stages can alter the repeatability of the K readings. If it is a little more advanced stage, if you're combining it with endothelial keratoplasty, if it's DMEC, it's okay because it has lesser effect on the posterior corneal curvature. But if it's DSEC, it definitely significantly affects the posterior corneal curvature, and you need to account for the hyperopic shift as well. And this needs to be explained to the patient. LVC is sometimes easily overlooked. If you see a patient with a significantly flatter K reading, take a closer look and ensure appropriate formulae are used. Barrett True K is extremely useful in these situations, using for both post LVC and post RK in these irregular corneas. Most importantly, try to use the integrated K values and take readings from 3 different measurements, and this definitely improves the accuracy of the outcomes. Again, if you have refractive surprises, which is common in these situations, if it's a small residual in these irregular corneas, you might as well leave it behind. But if it is significant, you could do a rotation IOL exchange or a piggyback IOL depending on the situation. So with meticulous preoperative planning and optimizing the surface and reducing the extent of irregularity, you can achieve satisfactory outcomes even in these irregular corneas. Thank you so much.
It's an excellent presentation, Shreyas, and thank you very much. I'd just like to highlight in post-LASIK, post-RK eyes, you said Barrett's True K formula, but total K doesn't play any role in this?
There is a Barrett True K TK also, which is available now, sir, and that can also be used, and it is quite effective.
Online.
In fact, the one thing maybe beyond the scope of this talk, but the TK value has been shown to add value not just with the Barrett IOL formula, but even with the Haigis TK, which is again being used with the total keratometry reading is also good. So having a formula which having a recording which integrates both the anterior and posterior corneal measurements with a toric fit, which is taking only the central 3 mm value rather than the larger value which is given by the Scheimpflug devices, seems to be the way to go at this point of time. And whether it is Barrett True K TK or a Haigis TK, they do work very well.
You will go with a trifocal toric in these eyes, post-LASIK, post-RK?
If it's RK, maybe no, sir, not in RK, but in post-LASIK, especially if it's been done in the later period with the more of the advanced laser beams that we use today, where generally the patient has the topography is fairly uniform, the extent of higher order aberrations are less, then I think it's not a strict contraindication for multifocals today as it was probably a decade and a half ago.
That's a topic for debate. I request Dr. Jeki, sir.
I concur with Dr. Shreyas. We have to see the topography, see how is the corneal shape, then we have to go ahead with the True K, Barrett True TK, what total value, corneal value, is a bit controversial. You can't get a true K value of no device can give it right now. It's only assumption and speculation. So whatever Barrett is, True K is working very well. That's also a regression formula. That's not any theoretical formula. A combination of theoretical and regression. So that's giving good result. Better to stick on that, except you have a large research laboratory where you can do it, then you can do. If you're a lone practitioner touching now and then one case, no. Just go for a Barrett True T. Right now, this gives 90% of the times they don't irritate you, patient. You try new formulas, your troubles will increase.
Thank you, sir.
Now I ask Dr. Meena Kumari to give the closing statement.
We have learnt a lot from the speakers, and this was a valid talk introducing the newer IOL, and happy to be with you. Thank you.
A very good afternoon to one and all. So moving on to the next session, I welcome you all for this session, Transcending Boundaries in Keratoplasty. I take immense pleasure in welcoming our chairpersons, Dr. Vanati Murugesan ma'am and Dr. K. Siddharthan sir. Now may I invite Dr. Sujata Mohan ma'am for to give us a talk on DALC or DSEC.